So, the arrows? Okay. So, I want to talk to you a little bit about spine surgery and how we got to where we are today. And listen, we go back a long time. This is a depiction from thousands of years ago of Krishna in India. And if you look there, that woman that she's trying to treat there has a hump on her back, and obviously a scoliosis patient. And thousands of years ago, they figured out that distraction technique. Although stepping on the toes and pulling on the neck may not be highly effective, they had the concept. I'm sorry. Now, before spinal surgery, there were tables in ancient Greece. The Hippocrates table was a distraction table. In Rome, Galen had a method of treating spinal deformity by putting traction on the patient and then walking on the patient's back. One of the first surgeries not for scoliosis was about 700 AD, when someone did a laminectomy on a slave who had been injured. I don't think that patient did particularly well. The father of orthopedics in the United States has often been said to be Louis Albert Sayre. And we have a connection with him at NYU because Bellevue is part of the NYU school system. And he was the first professor of orthopedics in the United States, in the first department of orthopedic surgery at Bellevue Hospital, and had a lot of famous things to his claim. Back then, the biggest cause of spinal deformity was Pott's disease, which is tuberculosis of the spine. And this was treated, believe it or not, because they didn't have antibiotics. They would put the patient in a brace or a cast because it would put the spine to rest, and that would allow hopefully the disease to heal itself. But as they got adept at creating these plaster of Paris jackets, which became later known as scoliosis casts, they evolved this traction technique. And were able to, they started treating scoliosis, idiopathic scoliosis. Albert Sayre was a real visionary. He started doing scientific models and understood that if he put a spine and created elastic bands to the spine, he noted that the spine not only went lateral, but it also rotated. And this was all the way back in 1877 that he did this. Some of the next two pioneers just happened to also be in New York. One of them was Russell Hibbs, who was at Columbia. He's also very renowned in the scoliosis world because he did one of the first papers on scoliosis and recorded the outcomes. Fred Albee was a contemporary of his and was actually part of the original NYU system at the New York Postgraduate Hospital. And these two pioneers did the first two spinal fusions in the United States. Hibbs was the chief at New York Orthopaedic Hospital. You may have heard of the New York Orthopaedic brace. It was one of the first braces for scoliosis. And he published his results for scoliosis. He was in World War I. He entered into the military as an advisor. He traveled down to Walter Reed Hospital, gave lectures. He also examined FDR and pronounced him fit to be president, and in 1932 died of a heart attack. Albee was from Maine, and he went to Harvard Medical School, came down and became a radiologist, and then he published a textbook in 1915 in reporting on spinal fusion for scoliosis, and really was very famous. And this was just his connection through the NYU system. Now, he's really the father of bone graft surgery. And basically, his maternal grandfather taught him the principle of grafting fruit trees. And if you take a branch from one and you shave it down and you shove it inside another, and then you tape around it, you would end up with an apple tree growing on a cherry tree stalk, or the other way around. So he took this technique and he introduced it into patients. And he took a piece of their tibia and shaved it down just the way his grandfather took a piece of a branch, and he shoved it into the spinous processes and created a spinal fusion. And he did this in patients initially with Pott's disease, remember, tuberculosis of the spine. And he would fuse that spinal deformity, which in those days was mostly a kyphosis rather than a scoliosis. But then he started to introduce this concept into scoliosis surgery and taking longer pieces of the tibia and curving them and then putting them into the spine. So he was really a visionary. This leads us to another great visionary, and of course, we've heard the term Harrington Rod, but who was Harrington? Harrington was an orthopedic surgeon, grew up in Kansas, moved down to Texas, had a bunch of kids in a polio clinic that could barely breathe and had curved spines, and it was too hot to put them in a brace down there. And so literally in his garage, he manufactured the first Harrington Rod and started implanting them into spines. And then over the next 20 years, this became the mainstay of treatment in the United States. And he had both distraction rods and compression rods. And literally yesterday, I was in my office, I read a radiology report, and with the modern instrumentation, the radiologist said, 2 Harrington rods in place in the spine. So it's just become a generic term for any spinal instrumentation. But I want to introduce this concept of how a worldwide evolution of physicians came to start thinking about scoliosis and how they could better the treatment. And these 2 gentlemen are from different parts of the world. Dwyer was from Australia and also took care of a lot of neuromuscular patients. And Hudson was in Hong Kong and treated a lot of patients with scoliosis, and they became very adept at doing anterior spine surgery. And Dwyer came up with a cable system for spine, and hard to get some of these old x-rays to really show well, but it was basically screws into the spine and some cables into the spine that was sort of, you could pull them down and correct the curve. Interesting, it's very similar to some things that are now going on today in the world. There are a lot of problems with the device. When you fixed the scoliosis and compressed it down, it tended to kyphose the spine, and in the lower part of the spine, as we know today, that's probably not a real good answer. So now we move from Australia to Germany, and this was a famous scoliosis surgeon, Klaus Silke, and he improved upon that cable that Dwyer had, and he said, well, let me put in a threaded rod. And we'll put this threaded rod in, and then I'll have a series of nuts. And literally, I remember doing these operations back in the mid-'80s, and you stand there with a little wrench. I mean, it was a very, very tedious operation. And sometimes these were done all by themselves, and sometimes these were done in combination with the Harrington Rod. Harms, as you heard today, Jurgen Hans, which is where the Harms study group gets its name, was a disciple of Silke. And I've seen a lot of spine surgeons around the world, and we have, by the way, excellent spine surgeons in this room who I all know personally. But Harms is probably the single best surgical technician I ever saw by far. And he came up with his own instrumentation, and he put a solid rod in connection with these rods, with these different screws that were going into the vertebral bodies from the front of the spine. And he was able to do very, very long constructs and to a certain extent did things that were not reproducible in the hands of the average surgeon. Now we move from Germany, we move to Mexico, Mexico City. This was another gentleman I had the pleasure to meet, Eduardo Luque. And he, once again, the old techniques were to use a Harrington rod, only have fixation at the very top and the bottom of the spine, put people sometimes in bed in a body cast for a while, other times walking upright in a body cast, sometimes using a brace postoperatively for 3 to 6 months. And he practiced in Mexico City. It was 100 degrees. I mean, it was humid. It was just inconceivable that his patients were going to be able to do this. So together with a neurosurgeon, he came up with this wiring system, and he would take these long rods, which had they were L-shaped, and so Luque L-shaped, Luque rods, they became known as. And the important part of this is that each of these wires goes underneath the lamina and he developed what was known as segmental fixation of the spine. In other words, instead of a hook at the top and a hook at the bottom, each individual vertebral body was segmentally fixed by something. And this became a very popular form of fixation. Sometimes it was matched to a Harrington Rod. Luque was from Mexico. Harrington practiced in Texas when they used to use Harrington Rod and Luque wires on the same patient. They used to call that the Tex-Mex operation. But anyway, Luque, they used to also use Luque rods for kyphosis, and it was really a mainstay in the 1980s for getting a lot of fixation into the spine. In the 70s, we became obsessed with the coronal plane. In other words, look at the patient from the front or the back, and you'd see the scoliosis, and everyone was talking about the coronal plane. In the 80s, now we were in Germany, we were in Mexico, now we're going to visit France. These two gentlemen, Cottrell and Dubussé, were pioneers at creating a hook and a rod system that's segmentally fixed to the spine. But because it didn't use distraction, you could use compression or distraction at any segment. You could maintain the coronal, the side profile of patients. And this was a big addition to spine surgery. And I put my first CD instrumentation, or Cottrell Dubussé instrumentation, in around 1988. And I was not a huge CD fan because it almost became a religion. The doctors who used CD, it was like they all belonged to the same church. But Dubussé was a brilliant thinker, and he visited us here in New York. And Stephen, you can see you're in that picture when you're a fellow up on a rooftop down in southern Manhattan. We had a great social evening. Now, CD instrumentation got introduced into the United States. As I said, it was a French system. And these three gentlemen, and Stephen's boss, Harry, who's not here with us today, Harry Shufflebarger, together with Ken Leatherman and John Hall from Boston, really brought about and introduced this system of segmental fixation with dual rods into the United States. Moving back to France was another mentor of mine, was Raymond Roy Camille. He was a charming gentleman born in the Caribbean, of French descent, moved back to Paris, became one of the leading surgeons in France, and he introduced screws into the vertebral body and popularized this technique. He was really the father of pedicle screws, which is really the basis of all the systems that we use today. And there were a few people, this Canadian by the name of Bouchard, and then there was another Canadian by the name of King who tried to use screws that were similar, but really Raymond was the father of pedicle screws, and I had the pleasure of learning how to do pedicle screws with Roy Camille showing me how to do it in a cadaver in his hospital back in the mid-1980s. And he originally came up with these screws and wasn't thinking about scoliosis surgery. He was using it for fractures and other things, and he was putting these screws through plates into the spine. Another father, so now we're in France, now we move to Korea. And in Seoul, Korea, Dr. Suk started putting these screws into the spine, in the thoracic spine, which was a little scary for a lot of surgeons at that time, and started to use segmental pedicle screws to fix thoracic scoliosis. And I can tell you that this was an uproar back then. People were thinking, he's a cavalier, this is too dangerous. And, pretty much today it is the standard of care, and everyone does this. So you can imagine that there's technical difficulties in putting screws into vertebral bodies that are rotated everywhere and then trying to connect them up with to a rod, and how do you bend the rod and get everything hooked up together. And then right around the same time, this concept of using polyaxial screws, which was the head of the screw sort of was mobile, and then that would allow you to put the screw into the bone in the proper area and then connect it to the rod. So now polyaxial screws became very popular and became a method for fixing scoliosis. And then there were hybrid constructs. You'd put screws in the bottom and hooks in the top, or wires in the middle, and all kinds of variations came about. And then some people said, well, we're trying to correct these curves, and you've got this screw that's highly mobile, and the head is going all over the place, and I'm trying to push the spine, and instead of pushing the spine, I'm just pushing the head of the screw. So people came up with the idea that maybe we needed something better than polyaxial screws. And actually, the first person I ever really heard talking about it, I don't know if I'm giving the right person credit for this, but Peter Newton, who was inside today, and you'll probably hear later, started talking about using uniaxial screws. And I think Baron Launer was a very early proponent of this as well. And using uniaxial screws to connect the rod to the spine, but the screw would allow you to push on the scoliosis and make the spine straight. As I said before, it's all about the technique and how do you get these screws to connect up to the rods. And we developed these reduction screws, and there's a lot of other things that have been used around the country, and different connectors try and connect everything up. And basically today you can take a largely curved spine, you can fix every vertebra, you can connect rods to them, and you can make these, you can pretty much move the spine to any position that you want within reason. So I've talked a lot about the way we fix to the spine, screws in the vertebral bodies, wires in the lamina, screws, pedicle screws, but what about the rods? Well, it used to be every rod in the United States was stainless steel. We had the old Harrington rods, we had different types of rods, but nowadays there's all sorts of new materials. There's titanium rods, there's titanium alloy rods, there's cobalt chrome rods, there's rods that are 4.5 millimeters, 5 millimeters, 5.5, 6.5, a quarter inch, all types of different types of rods, but pretty much all the rods were round. In the last few years, and I attribute this to Dr. Bawachi, who has subsequently retired from New York and is now practicing in Ghana. He came out with a non-round rod, and this allowed it to be stronger in certain planes, and it was probably the most recent addition to this evolution of surgical techniques that we used in the spine. So I'm pretty much going to end it there. I'll just tell you that there is a very rich and dramatic history for scoliosis treatment. It literally dates back to antiquity. The surgical techniques are way over 100 years old. When we talk to you about the results of surgery and scoliosis, we're not just talking about recent history, we're talking about 100 years plus of experience with patients. And the present day things that are done are built on the foundation steps of many great men and women who did this literally all around the world. And there's many, many people that I left out of this talk, and it's just beyond the scope of this talk. But I thank you for listening, and I hope it was of some interest.